Hello, everyone, and welcome to our question lab. We're happy to have you here. As you guys know, we do this every Tuesday at 6 p.m. Eastern. Today, we will be covering cardiac physiology. My name is Sean. I've been with RX Coach, which is our new tutoring program. We'll talk about it a little bit later, about a year and a half. And with me today is Dr. Paras Fakari, and I'll let him introduce himself.
Hey everyone, my name is Paras. I am a resident physician in dermatology at UT Southwestern here in Dallas, Texas. I originally graduated from pharmacy school in St. Louis, Missouri, and then went back home to Michigan to complete medical school. I've been with RX a little under a year now, primarily as an RX coach, which we'll talk a little bit more about, but I'm working one-on-one with students, primarily regarding the USMLE Step 1.
Excellent. We're happy to have Dr. Fakari here as always. We also have some wonderful panelists with us here today. As you guys can see on your GoToWebinar control panel, you'll see a little question box. And if you expand that question box, you'll be able to ask questions to our panelists that will try their best to answer all of your questions. Our first panelist today is future Dr. Ari Stone. I'll let Ari introduce himself.
There we go. Can you guys hear me now?
Yes, Ari.
Yep.
Oh, perfect. Hey guys, my name is Ari Stone. I am a fourth-year medical student at the University of Wisconsin. I've been a tutor for a while now, but I've just gotten on board a few months ago as a new RX coach, so very exciting. And yeah, look forward to chatting with you guys, and feel free to ask any questions you may have.
Excellent. In addition to Ari and Paras, we also have Kate and Jeff joining us, and they'll be trying to answer your questions as well. So welcome to all of you once again. And with that, let's meet you guys. You've had a chance to meet us, so let's see who is in the audience tonight. So I'm going to launch a poll, and I'll let you guys answer. What exam are you currently preparing for? So once again, this is the same format that we'll use for all of our questions. You'll be able to input your responses just like you are here with this question. So we'll give you guys a couple of seconds to respond, and then we'll move on. Remember, as always, we do a webinar giveaway at the end. So we will be giving away 2 raffle prizes. So make sure you stick around until the very end, because you must be present to win. So make sure you stick around until the very end. And for those of you who do not have your calendars marked, on July 20th, Dr. Vicaria and Dr. Tao Lee will be doing a Secrets of the USMLE webinar on the topic of pharmacology. So make sure you tune in for that. And once again, it looks like most of you guys are studying for the Step 1, and with a lot of you guys studying for the basic science assessment as well. So we're happy to have you guys here, and hopefully everybody will learn from tonight's session. With that being said, we'd like to know, when are you guys planning on taking your tests? We'll give you guys a couple more seconds to input your responses. Wonderful. We also have a very special offer for you guys that we'll reveal at the end, and Jeff will go over that with you guys. Looks like a lot of you guys have responded. Let's take a look. So it looks like a lot of you guys are taking it here towards the end of the year, with some people taking it this fall. A few of you guys are taking it this summer, and a lot of you guys aren't sure yet, which is completely fine. So once again, we want to welcome all of you to our question lab, and we're happy to have you. Without much further ado, I want to tell you a little bit about RX Coach. So RX Coach is our new tutoring program with tutors like Dr. Vicaria and Ari Stone and many others. And we've had a lot of great success stories, and I'll share one with them. I'll share one of those with you later today. And what we do here is we work with students on a one-on-one basis and coach them and guide them to help them reach their maximum potential. And we'll be using today our methodology that we use in RX Coach as we do these 4 questions on cardiac physiology. So with that, let's go ahead and get into our first question of the evening. And for those of you who took a look at the brick that we recommended you guys to take a look at, should have a little bit of a head start with this question. So here we go. As you guys can see, the answer choices are missing here, and we do that on purpose. The first step that we always take in our coaching program is to have the students cover up their answer choices. And the reason for that is we don't want students to have their thought process guided or dictated by these answer choices. And we certainly don't want you to see one that you're unfamiliar with, and that may cause you to panic as you're trying to read the vignette and come to the correct answer. So we've covered those up for you. And after we cover that up, what we're going to do is read the lead-in of the question together. And the lead-in is the last sentence. So we're going to read that here together. The opening snap heard during cardiac auscultation of this patient best corresponds to which of the following letters on the pressure volume loop? And once we read the lead-in, we like to ask our students how many steps you think this question will require for you to come to the correct answer. So an example of a one-step question could be where they ask you for the diagnosis. An example of a two-step question could be where they ask you, what is the treatment for a diagnosis? And an example of a three-step question could be when they ask you, what is the mechanism of action for a treatment for a diagnosis? So with that in mind, I'll give you guys a couple of seconds to input your response to how many steps you think this will take into our question box. And let's see what you guys come up with. We have a lot of people saying 2 steps so far. Excellent. And Dr. Vicario will go over how many steps it will require here in a moment. So we have some people saying 2 steps, some people saying 3 steps, and we will go over that along with the correct and incorrect answers like we always do here in these question labs. With that being said, let's go ahead and read move on to the next step, which is to read the actual vignette in the question stem. Now, in our coaching sessions, we'll stop you after every sentence and ask you, what are you thinking? What do you want to highlight? What's important? What's a distractor? What are you thinking? What's on your list of differential? But because we can't do that individually with all 200 plus of you today, I'll stop briefly after each sentence and give you guys a moment to gather your thoughts. A 68-year-old woman who immigrated from India comes to the emergency department because of increasing difficulty breathing on exertion. She also reports coughing up blood-stained mucus during the past several weeks. She has been otherwise healthy, but says that she had frequent sore throats as a child. She does not smoke or drink alcohol, and she does not take any medications. Diffuse crackles are heard on pulmonary auscultation. Cardiac auscultation discloses the presence of an opening snap and diastolic rumbling murmur best heard at the apex. And once we read the stem, we will read the lead-in again. The opening snap heard during cardiac auscultation of this patient best corresponds to which of the following letters on the pressure volume loop. And we'll give you guys a couple of seconds to take a look at that diagram as I hand it off to Dr. Vicario.
Thank you, Sean. So first, I think it's, let's talk about how many steps we think this question might be. So I think first, I think we need to figure out what that opening snap is talking about. And then I think we need to figure out, so once we know that, maybe what kind of murmur we have, and then what does that murmur correlate to, and then where on that graph is that point. So I think maybe a 3-step question, figuring out what kind of murmur we have, what does that correlate to, and then where on the graph would you find that? So maybe a 3-step question. So normally, this is kind of a different question, but when we're going through answer choices, we like to make sure that we work our way from the bottom and work our way towards the top. That way you get through all the answer choices. You're not biasing yourself. You're not getting trigger happy and seeing an answer choice that you like and then not going through the rest. This is a little bit different because they're just letter choices on a pressure volume curve, but we'll go ahead and just mention that there are 5 potential answer choices, E, D, C, B, and A. And then as you can see there on that graph, what those all correlate to. So we'll give everyone a couple seconds to gather your thoughts on that. Take a look at that graph very closely, and then go ahead and select the answer choice that you think is correct, and we'll talk about it in just a minute.
And you guys may not be able to see that diagram once I open up the poll, so I'll give you guys a couple more seconds to take a look at it and come up with your answer choice, and then I'll launch the poll and have you guys submit your responses. So we'll give you guys a couple more seconds to take a look at the diagram. and then we'll ask you guys to submit your responses. And once again, the question here is, the opening snap heard during cardiac auscultation of this patient best corresponds to which of the following letters on the pressure volume loop? And with that, let's launch our poll and have you guys submit your responses. And it looks like some of you guys have started to answer. We'll give you guys a couple more seconds to submit your responses. And it looks like a lot of you guys are on the right track. So far, so good. Excellent. Let's see how you guys did. So 53% of you guys picked answer choice A, and 20% of you guys picked answer choice B. Let's see what the correct answer is. And the correct answer is A. The correct answer is A. And with that, I'll hand it back off to Dr. Beccaria.
Thank you, Sean. Yes, great job, everyone. As you can see here, we have a nice diagram of that pressure volume loop. So first of all, we have an immigrant patient here, and they told us in that question stem that this patient is having frequent episodes of pharyngitis, dyspnea, hemoptysis, and a diastolic murmur with an opening snap. So this presentation is characteristic of mitral stenosis. So I have a couple questions for you guys. One, why did this patient potentially get mitral stenosis? And two, what does that opening snap correspond to? So go ahead, and if you look at the right side of your screen, you should see a question box there. Go ahead and post in there, one, what you think, why this patient maybe developed mitral stenosis, and two, what does the opening snap correspond to? And we'll talk about it in just a couple seconds.
We have a lot of people saying rheumatic fever and positive history of rheumatic fever. So Dr. Beccaria.
Yes, absolutely, rheumatic fever. So this was an immigrant patient, and as we know, untreated pharyngitis can lead to rheumatic fever and mitral stenosis. So great job. Now, what does that opening snap correspond to? Let's talk about that. So that opening snap that's characteristic of mitral stenosis, that results from the abrupt halt of that stiff mitral valve as they open during early diastole. So that's what it corresponds to, and that corresponds to near point A on that curve. So, and that classic diastolic rumble that they tell you about happens after the opening snap as blood turbulently passes through that stenotic thick mitral valve. So in this case, the answer choice is A, but let's kind of walk through this pressure volume loop so we understand what's going on. So systole is represented by, and if we could go back to, actually, if we can just stay on this image from kind of where just below point 3, where the mitral valve opens, there's an arrow pointing to that. So if you look, that's what this question is talking about. Now, the next point, the mitral valve closes, that's when you have the beginning of systole. So that point represents the beginning of isovolumetric contraction. So that's when you have left ventricular contracting, but you don't have a change in volume. And that is after the mitral valve is closed, but before the aortic valve has opened. So as you can see there, once the aortic valve opens, then the left ventricle contracting pushes blood out of it, and then the left ventricle volume drops. After that, you then enter into the aortic valve closing, which you can see at the very end of that decrease in volume. And then that point is when you have diastole. At that point, you have isovolumetric relaxation, which is between the aortic valve closing and the mitral valve opening. and you have a rapid decrease in pressure of that left ventricle. During this stage, no blood is entering or leaving because both the mitral and aortic valves are closed. However, from the point of the mitral valve opening to the point of the mitral valve closing, that's when you have ventricular filling. And that is when the ventricle pressure will thus rise. The ventricular volume will thus rise. So those are the other answer choices in that question as to why those are incorrect. And then this question, as most of you got right, would correspond to the mitral valve opening or question answer choice A.
Excellent. Thank you, Dr. Beccaria. So with the physiology question, I appreciate how we spent some time kind of going over that pressure volume loop. It's a very high yield topic. You're likely to see it on your exam. So make sure you familiarize yourself with that diagram, as it's very important, not only for your exam, but also, of course, for your future practice as a physician. So with that, we will now move on to our second question of the evening. And once again, you guys will see that our answer choices are covered up. And for those of you just joining us, that is by design. We cover them up because we don't want the answer choices to guide your thinking or to dictate your thought process. And we certainly don't want you guys to see an answer choice you're unfamiliar with, and that may cause you to panic as you're reading the question and trying to come to the right answer. So after we cover up the answer choices, we will read the lead-in together. And here we go. Injury to which of the following areas in the diagram is the most likely cause of this patient's symptoms? I'll give you guys a couple of seconds to let us know how many steps you think this question will require. I'll let you guys input those responses into the question box. So is this a one-step question, a two-step question, a three-step question? Let us know what you guys think. We have some people saying one step, some people saying two steps. And it's important to stay organized to make sure you're taking the right steps and having that organized thought process so you're not jumping from one to another and missing a step which may cause you to get to the wrong answer. So looks like we've got some great responses, and Dr. Beccaria will go over that with you guys here shortly. So after we read the lead-in, we're going to read the stem together, and here we go. A 42-year-old woman is brought to the emergency department after being involved in a motor vehicle collision. She was a restrained passenger in a car that struck a light post while traveling at a high speed. She is conscious and reports difficulty breathing and severe pain in her chest and back. Temperature is 98.2 degrees Fahrenheit. Blood pressure is 89/52, and pulse is 130. Chest X-ray shows a widened mediastinum. Injury to which of the following areas in the diagram is the most likely cause of this patient's symptoms? And you guys see the diagram there on your right. So I'll give you guys a couple of seconds to take a look at that while Dr. Beccaria goes over these choices with you.
Thank you, Sean. So again, trying to figure out how many steps this could be. I know some of you said one, some of you said two. I think this is probably a two-step question. I think one, we need to figure out what's going on, what is the diagnosis where we're seeing these symptoms? And then two, with that diagnosis, where's the most likely injury happening? So I think probably a two-step question. So again, we're going to start our way at the bottom and work our way up. This way we don't bias ourselves and we get through all of the answer choices. So answer choice E, descending aorta. D, aortic isthmus. C, left subclavian artery. B, aortic arch. And A, ascending aorta. So once again, we'll give everyone a few seconds to gather your thoughts, take a look at that image one more time, and then we'll go ahead and have you guys select an answer choice.
Yeah, excellent. And this is the question writers are being nice in this one because they actually told you what each of these areas and labels are. So you may not get that on the test. You may just get the letters without the explanation or description of what you're actually looking at. So that should hopefully make this question a little bit easier for you guys. We'll give you guys a couple more seconds to respond. And it looks like a lot of you guys have responded. Give you guys a couple more seconds. And then we'll go over the correct and incorrect answer choices. You know, and while you guys are doing that, I want to address something. I see a lot of people asking us in the question box, how many questions should you do, or how many times should you do a certain question bank? Keep in mind that science has not proven that doing one question bank more than one time is effective at all. We recommend that you do a minimum of 3,500 unique questions and not repeat any question bank more than one time. All right, let's take a look. Looks like 45% of you guys picked answer choice D, which is aortic isthmus. And with that, we'll hand it back off to Dr. Viccaria.
Thank you, guys. Yep, great job with that question. So actually, I think there is a diagram that we have there that kind of talks about what's going on. So in a traumatic aortic rupture, we'll keep this in mind before we go to the question. It's due to trauma and or deceleration injury, and most commonly at the aortic isthmus, or just distal to the origin of the left subclavian, and you can see a widened mediastinum, okay? So what was going on in this question that gave us those clues? So they told us that this was a 42-year-old woman who was a restrained passenger in a high-speed collision involving rapid deceleration. She has dyspnea, severe chest and back pain, and that widened mediastinum on chest x-ray. So this presentation is concerning for traumatic rupture. So during this injury, a part of the aorta is actually torn, resulting in profuse bleeding. So you can have tearing pain in your back, dyspnea, hoarseness, and the aortic isthmus, which is, as we mentioned, is just distal to the origin of the left subclavian, is particularly susceptible to tearing and is the most common site of traumatic aortic rupture. And that's partly because it's relatively immobile. So it makes it very susceptible to those shearing forces during deceleration. Can you guys name one major reason why it is particularly immobile or susceptible? Go ahead and post in that question box why you think that area is very susceptible or very particularly immobile, and we'll talk about it in just a second.
And we just had a student ask us, you know, I always knew this was the answer, but I wasn't sure why it's the right answer. I never understood the mechanism behind it. So I'm glad that Dr. Viccaria asked you that, and he'll be going over that with you guys shortly. So for those of you who asked that question, your answer is coming up here in a second. Looks like some people are saying adhesive from ligamentum arteriosus. Some people are saying ductus aorticus, and its attachments. Dr. Viccaria?
Yes, absolutely. Great job, guys. So the isthmus is particularly susceptible and particularly immobile because it is tethered to the pulmonary artery by the ligamentum arteriosum, which, remember, is a remnant of the ductus. I guess another way to think of it is attachments as well. So it's tethered together. That's why that area is very susceptible. Now let's talk about why the other answer choices are incorrect. Answer choice E, descending aorta. So overall, this is not a very common area. It's not as immobile as the aortic isthmus is. Answer choice C, left subclavian artery. Injury to this could lead to dyspnea. It could potentially lead to a widened mediastinum. However, you may see other things. You may see a diminished or absent radial pulse in the left arm, maybe brachial plexus palsy. This is not a very common site of injury because it's not tethered down like the aortic isthmus. Answer choice A and B are also potential sites of aortic rupture. However, they are not as common as the aortic isthmus. And remember, as we just talked about, that's because the aortic isthmus is tethered to that pulmonary artery by the ligamentum arteriosum.
Excellent. Well, looks like you guys did a great job with that question. And once again, this is a high yield topic. They like to ask about these deceleration injuries. So we wanted to make sure we covered that today as we talk about cardiac physiology. So with that, I want to talk to you briefly about RX Coach. I see a lot of our coaching students here on the webinar. I want to welcome all of you guys here. You know who you are. Our RX coaching program is really beneficial for students because, as you guys know, everybody in your class learns differently. They think differently. You guys have different strengths, different weaknesses. You apply that knowledge differently. And although there's lots of USMLE review resources out there, they're all kind of cookie cutter. They're not tailored or personalized to you as a student, focusing on your strengths and weaknesses. So what we do at RX Coach is we first start off with a 160 question assessment. Based on that assessment, we then talk to you about that assessment and analyze it. And then we come up with a personalized study plan. And you will be coached by one of our highly trained RX coaches. And these coaches will help motivate you, keep you on track, make sure you're able to understand the information, retain it, and apply it. And we work on the knowledge and the content, but we also work on test taking skills. So you can really learn how to dissect these questions and maximize your potential. Just like the best athletes in the world have their coaches and personal trainers to help them reach their peak potential, we have coaches to help you reach your maximum potential on test day. And as you can see here, we have one of our success stories from a student from SGU. I'm very impressed with the Scholar RX program. I reached out after feeling very discouraged after scoring low on practice exams. I was matched with one of my coaches who immediately helped me identify strengths and weaknesses. These sessions are not lectures. They are one-on-one interactive sessions. My coach and I worked through practice questions together. He asked me questions and made me think out loud in order to understand the process. When I was completely stuck, he would teach me the concept. However, he made me work for the answers by really getting me to think through the problem. This was a perfect strategy for my learning style. It was helpful to identify why I was missing certain questions. He also taught me test checking strategies and encouraged me throughout the entire process. I raised my score over 35 points from my diagnostic practice test to my step 1 score. And she ends by saying, I would highly recommend this program to anyone needing a tutor. So if you're interested in learning more about RX Coach, we encourage you to visit us at rx-coach.com, where you can learn more about the program and even schedule a free consultation to discuss the program and how it can benefit you. So if you want to learn more about the program and talk to us about it, please schedule a free consultation online. If you want some generalized study advice or a free study planner, please visit us at firstaidteam.com. So with that being said, I will now move on to the third question of the evening. Once again, the answer choices are covered up. As you guys know, we do that every single time at the very beginning. And after we do that, we read the lead-in. So here we go. In which of the following cardiac structures was the catheter most likely situated during the first pressure reading? And now that we've read that, I'll give you guys a couple of seconds to respond and let us know how many steps you think this question will require. You guys can input your responses in that question box as always. Like we have several people saying 1 step, some people saying 3 steps, some people even saying 2 steps. So we'll keep all that in mind, and Dr. Vicari will be going over that with you here shortly. So now that we've read the lead-in and thought about how many steps will take us, let's read that question stem together. Now, of course, in our coaching sessions, we'll stop after every sentence, ask you what you think is important, what clues are present, which things may be distractors, and we'll ask you what you're thinking and what's on your list of differentials. We can't do that here today with all of you individually, so what we'll do is just pause after each sentence and give you guys some time to gather your thoughts. So here we go. As part of an experimental protocol, a normal test subject undergoes a catheterization procedure in which the catheter is first placed in the femoral vein and then advanced towards the heart. During this catheterization, pressure readings at one location range from 9 to 25. As the catheter is advanced forward, the pressure range subsequently becomes 9 to 12. In which of the following cardiac structures was the catheter most likely situated during the first pressure reading? And with that, I will hand it off to Dr. Vicari.
Thank you, Sean. So when thinking about how many steps this question could be, I think it's a little tough. I think Those saying 1 or 2 are probably right. I think one, you know, if you take a look at where that pressure initially was, if you know what structure that's in, you may be able to answer this question, but I think you also need to analyze the change in pressure that's going on from the movement as it's advanced forward, and then knowing what the 2 different structures are. So I think it's probably between those 2, 1 to 2 steps, I think is probably accurate. In terms of the answer choices, let's walk through those. Answer choice E, right ventricle. D, right atrium. C, pulmonary artery wedge. B, pulmonary artery. And A, left ventricle. So go ahead and select the answer choice that you think is a correct answer, and we'll talk about it in just a few seconds.
Excellent. Thank you, Dr. Vicario. I'll give you guys a couple of seconds to respond here, and make sure you guys stick around till the end, because we do have a raffle and 2 of you will win some prizes. We also have a very special offer for you guys, so you must be present to win. And you know, every now and then we'll have people that win that aren't here, and so we'll have to draw more names. So, you know, make sure you stick around. You might get lucky here this evening and win some valuable resources. We'll give you guys a couple more seconds to respond. Looks like a lot of you guys are responding. You guys are on the right track, so we're happy to see that. Excellent. Let's take a look and see what you guys selected. So it looks like 33% of you guys picked right ventricle, and in second place, almost tied actually, were 2 choices, pulmonary artery and right atrium. So let's see what the correct answer is. And the correct answer is B, pulmonary artery, and 23% of you guys picked pulmonary artery. And with that, I'll hand it off to Dr. Vicario to talk to you about why that is the correct answer and why the other ones are incorrect choices.
Thank you, Sean. So yeah, this is a tough question. I agree. I think there's a couple ways to look at it. One, you know, do you know the pressures of the different structures, and based on that, are you able to answer this question? Or 2, even if you don't, can you look at the change that happened as it was advanced forward, and then kind of deduce which one it can be? So they told us in this patient, the catheter with the balloon tip was progressively advanced into the vena cava, and then that's how it measures your pressure. So initially, the catheter recorded a pressure of 9 to 25 millimeters of mercury, and then upon advancement, the pressure dropped to 9 to 12 millimeters of mercury. So keep that in mind, the pressure did drop. So now if we take a look at that diagram that Sean had pulled up, you can see there that in the pulmonary artery, which is coming right off of that right ventricle, that is consistent with the pressure readings we were seeing between 10 to 25. And then if you advance it from the pulmonary artery into those pulmonary capillary, or the pulmonary artery wedge or capillary wedge, you can see that the pressure does drop to 4 to 12, which is consistent with what we were seeing in this patient when it was advanced, as it decreased to 9 to 12 from 9 to 25. So let's talk about why the other answer choices were incorrect, and we'll look at this diagram as we do that. Answer choice E, so the right ventricle. So I think initially, sure, if you were seeing a pressure of 9 to 25, that could be the right ventricle, but if it were to then be advanced, it would be advanced into the pulmonary artery, and the pressures would be roughly the same. Maybe a little bit of a higher, lower number, if that makes sense. But what we're seeing in this patient is that it did decrease, it did drop with an advancement. So it's likely not going to be the right ventricle. Similarly, with the right atrium, you would see an increase in pressure as you advance it from the right atrium to the right ventricle. And what we saw in our patient was actually a decrease in pressure. So that would be an incorrect answer as well. Pulmonary artery wedge, those pressures are much lower than what we were seeing in this patient initially. They said the initial pressure reading was 9 to 25. And as you can see there, that those pressures that you see in the pulmonary capillary wedge is is significantly less. And then lastly, left ventricle. Obviously, as you can imagine, the left ventricle, which pumps blood throughout all of the body, has a pretty high pressure gradient and pressure range within it, as you can see there in that diagram, and is much higher than what we saw in this patient on that initial reading. And furthermore, if you were to have it in the left ventricle and then advance it, the next structure would be the aorta, which also has a very similar and also high pressure as well. So also likely an incorrect answer. So one of the takeaways from this question is that, you can often use your knowledge, obviously, to answer some of these questions if you automatically knew what the pressures were in each structure. But if you also worked and tried to deduce, well, there's a pressure decrease, what structures of the heart lead to a decrease, if I were to advance it, you can kind of use your physiology knowledge a little bit to help answer these kind of questions as well.
Excellent, and thank you very much for that explanation. So, we've done 3 questions. We've got 1 question left, and then we will, we'll talk about next week's question lab. We'll talk about the webinar coming up, and we'll do our raffle. So make sure you guys stick around. So 3 questions down and 1 to go. So here we go. Once again, as you guys can see, the answer choices are covered up, and we will begin by reading the lead-in together, okay? Which of the following abnormalities is most likely in this patient? Which of the following abnormalities is most likely in this patient? Once again, we'll give you guys a couple of seconds to respond and let us know how many steps you think this question will require. I know a lot of you guys are asking about next week's topic. Next week, we'll be covering pulmonary pathology or respiratory pathology. So looks like a lot of you guys have responded in the question box here, and let us know that you guys think it's 2 steps, or some of you guys say it's 3 steps. And once again, we'll go over that here shortly. So now that we've read the lead in, let's go ahead and read that question stem together. A 22-year-old man comes to the emergency department because lately he sometimes feels dizzy. His heart seems to beat very rapidly for a few minutes, and then he passes out. The patient says nothing like this has ever happened to him before, but does mention that his father had heart problems in the past. The physician finds an anxious-appearing young man with no murmurs, rubs, or gallops on auscultation. His pulse is 160, respirations are 16, and blood pressure is 92/48. An ECG is shown. And we'll give you guys a couple of seconds to take a look at that diagram. And then we will read the lead in again. Which of the following abnormalities is most likely in this patient? And with that, I will hand it off to Dr. Viccaria.
Thank you, Sean. So I think this is probably a multi-step question. So 1, we need to figure out what is going on. You're giving us a slew of symptoms and signs. So I think we need to figure out what exactly is going on. I think you could take it a step further to figure out, without giving it too much away, kind of subclassify that as to what is going on within that. And then 3, what would result when you look at those answer choices? What would be another abnormality you would see as a result of that? So I think maybe a 3-step question here. So let's go ahead and talk about those answer choices. So answer choice E, reduced ventricular filling during diastole. D, inherited myocyte ion channel defect. C, increased sympathetic tone. B, increased conduction across the AV node. A, delay of conduction across the AV node. So go ahead and take a look at that EKG one more time, gather your thoughts, and then go ahead and select an answer choice when you are ready, and we'll talk about it in just a couple seconds.
Excellent. I'll give you guys a couple of seconds to look at that EKG one more time before I pull up the poll. Once again, next week we'll be covering pulmonary pathology, so respiratory pathology next week. And on the 20th, we have our webinar with Dr. Vakarian and Dr. Tao Li, and that will be on the topic of pharmacology. So now that you guys have taken a look at the ECG, I will give you guys a couple of seconds to select your responses. So give you guys a few seconds. Excellent. See, a lot of you guys are voting. Remember, if this is a little bit of a challenging question, so on test day there is no penalty for guessing, and don't leave a question blank on test day. So if right now you feel like you don't really know the answer choice, go ahead and take your best shot, give it your best guess, and let's see, and we'll all learn from it together. Cardiac physiology is one of those topics that generally gives students a hard time, but it's easier if you can approach it systematically, do some practice questions, keep your thought process organized, and we have some wonderful resources you can use, and I'll be going over one of them with you here in just a little bit. So looks like a lot of you guys have voted. Let's take a look. Looks like we had 30% of you guys pick answer choice B, increased conduction across the AV node, and then tied for second place for answer choices D and E, inherited myocyte ion channel defect or reduced ventricular filling during diastole. Let's see what the correct answer is. The correct answer is E, reduced ventricular filling during diastole, and 23% of you guys got that right. So this was a challenging question. Once again, it is a high yield topic. A lot of you guys, I think, had the diagnosis right, but weren't able to go that extra step to see what would actually be happening. And Dr. Vakarian will be explaining that to you here now.
Yep, thank you, Sean. Yep, great job, guys. Definitely a very tough question. So they told us that this 22-year-old young man has a family history of heart disease, and he's complaining of syncope, palpitations. So before we talk about anything else going on about this patient, when you hear that, a young man with a family history of heart disease, now with syncope and palpitations, what are a couple things that should be coming into your mind? What kinds of diseases, cardiac diseases? Go ahead and post in that question box what you think should be a couple things that should be coming to mind are, and we'll talk about it in just a second.
We have a lot of people saying Wolff-Parkinson-White and delta wave. We have some people saying HCM or hypertrophic cardiomyopathy. Some people saying tachyarrhythmias.
Yes, absolutely. Great job, guys. So a couple things you should be thinking are, one, structural heart disease like HOCM or hypertrophic obstructive cardiomyopathy, or conduction disorders like Wolff-Parkinson's-White. So in this patient, they told us that there were no murmurs and the physical exam was otherwise normal. So in that case, HOCM is less likely. And on top of that, we also have some EKG abnormalities here. So this is Wolff-Parkinson-White syndrome, and it's caused by an accessory conduction pathway through the bundle of Kent. So essentially what happens is you have conduction of an electrical signal to the ventricles before the signal is conducted through the AV node. So you actually have the ventricles depolarizing a little bit early, and that's why you have that little curve there, or that delta wave. And it leads to a little bit of a wide QRS complex. So then what happens is the AV node signal reaches the ventricles later, and so depolarization is prolonged. So the early ventricular depolarization that happens, as we talked about, leads to contraction of the ventricle earlier than would normally be expected physiologically. As a result, as you can imagine, if you have earlier systolic contraction of the ventricles, you're going to have less diastolic relaxation or filling of the ventricles. Thus, you have decreased filling time that then causes decreased ventricular filling during diastole, which is answer choice E. So hopefully that made sense. Once again, Early ventricular depolarization or contraction leads to a little bit longer systole and thus a little bit less of filling time for that ventricle to get filled up. And because of that, you then have a decreased preload that gets pumped out. So let's talk about the other answer choices, which some of these were also highly selected, and talk about why they're incorrect. Answer choice D, inherited myocyte ion channel defect. So these are the cause of some congenital syndromes, such as congenital long QT syndromes that may lead to sudden cardiac death. However, these would not lead to the characteristic EKG findings that we're seeing here of that nice sloped delta wave of the beginning QRS complex. Answer choice C, increased sympathetic tone. So this increased sympathetic tone would lead to an increase in heart rate, which would be more sinus tachycardia. You would not be having the abnormal EKG changes that we're seeing here. Answer choice B, which was also, I think, the most selected answer, increased conduction across the AV node. So this would lead to an increase in heart rate. However, it again would not lead to those EKG changes that we're finding, which are happening because of early repolarization because of an accessory pathway. And lastly, answer choice A, delay of conduction across the AV node. This is the cause of actually AV block, which would lead to a prolonged PR interval. In this patient, we're seeing a shortened PR interval, and actually kind of a little bit opposite of what's going on here. So in this question, as Sean had mentioned, this is kind of a multi-step question where I think many people may have picked up on what's going on, but then taking it a little bit further with that physiology to get to the correct answer in this question. But overall, great job today, guys.
Excellent. Thank you, Dr. Beccaria. And that's exactly right, right? So a lot of you guys were able to say Wolf, Parkinson, White, but not go that extra step to get to the correct answer. So if you guys missed this question, you know, take a look at some of our resources. I'm going to go over one shortly. But if you feel like you'll benefit from some one-on-one coaching with some of our highly trained and certified RX coaches, visit us at rx-coach.com. We recently had a success story with somebody going up 70 USMLE points. That's a huge, huge increase. So, you know, take a look, schedule that free consultation if you want that one-on-one guidance to really maximize your potential on these really, really important exams that you guys are going to be taking. So without, you know, much further ado, I want to kind of show you guys something that you guys can use to keep your study organized and efficient. So one of the resources that we've launched recently is called RX Bricks. And for those of you who have RX 360, it's now RX 360 Plus, and you get bricks with it. So that was really nice of the leadership here to do for you guys. So here is a brick on mitral stenosis, which was a topic of the first question we did this evening. And as you guys can see, each brick gives you a time limit of how long it will take you, an estimated time limit. And you have your learning objectives clearly outlined here, right? So define mitral stenosis, list and explain the common causes, describe the clinical presentation, and then describe the treatment. And we go through this brick to learn about mitral stenosis. We have some little flashcards here that we can use to test our knowledge. And as we scroll down, we will see clinical correlations as they're relevant. We'll see those. And as we continue to go down here in this brick and learn about mitral stenosis, we'll eventually get to a summary of the key takeaway points that we want you to learn after reviewing this brick. And then we have some practice questions. You guys can really test yourselves and see how you guys did. And in order to get an explanation, you have to select the right answer. And once you do, you'll get an explanation of the correct and incorrect answer choices. After that, you guys can review those learning objectives and mark off your confidence levels. See if you guys are comfortable with them. You can mark them off. And if for some reason you want to go deeper, you just didn't get it fully, or you don't think you're 100% comfortable with it, we tell you exactly where to find that information in first aid. And you can quiz yourself with these flash facts and study with flash facts. You can go deeper and watch express videos to really learn more about mitral stenosis. And then, of course, you can practice with COMLEX And all three of these tell you exactly how many cards or videos or questions you have and approximately how long it'll take you to get through that material. So it's a really nice way to stay organized and approach things topic by topic. So I encourage you to take a look at bricks. This microstenosis brick is actually one of our free brick previews. So you can actually go there and take a look at this brick, even if you don't have a subscription. So if you don't have a subscription to RX 360 Plus, I encourage you to sign up for the free trial. Take a look at these resources. So many people have used them to their benefit, and they're really, really effective. So be sure to take a look.